Right, okay. So good afternoon, everybody, and thank you for coming to the webinar. I'm Alex O'Neill. I'm the head of compliance here at Code and for iComply, helping out with the CPD site or device farm as well now. And we're we're fortunate today. We're going to have a presentation by Victoria Marsden and John Milne from the CQC. John is the Senior National Dental Advisor. Did I get that right, John?
You did.
Fantastic, and I think he no introduction is needed, but I'm sure he'll introduce himself as well when he gets to that. But we're very fortunate as well, and it's very gracious of the CQC to also allow us to have Victoria Marsden here with us. Victoria is the inspection manager for the north of England. There are 4 inspection managers. They run the teams to do the inspections. So John's very involved on the strategic side. Victoria does get involved on that as well. Victoria's very much on operations as well as implementation. So it's really good to have both sides of the coin here with us today. And the presentation, we've titled it the Imminent Changes to CQC Assessment and the Future of Regulation. What I've noticed being in this role for about 6 years now and being involved in dentistry for longer than I can remember is that these things seem to be on a 5-yearly cycle. The last big changes we had, I don't think this is going to be as big, but we'll see. The last big changes we had were when we had the new regulations and the key lines of inquiry and the new inspection regime in 2015. Obviously, we've now had a global pandemic going on, and the CQC timed in with the time that the CQC would probably normally look to refresh things. So it's kind of the two things in tandem that have stopped, and we've got the ESF in place, but I'll let them talk about that. And we've got changes coming next year. I think it's May next year, which is when this should change. I think for anyone who is an iComply member, so this is me talking to the membership. We held your hands. Don't worry, we held your hands through the last set of changes, and we maintained a really high pass rate when other people were not, other practices were not having such a good day. My statistics at the time were that 20% of practices started failing overnight when the regulations changed in 2015. We maintained, I think it's about 94% pass rate at that time. So we've done this before. We've been supporting practices for 40 years. So if you are a member, we'll hold your hand through this. If you are concerned about changes at all and you're interested in iComply, then as if by magic, a pop-up will appear on the screen right now to if you would like to book a demo to have a chat to our team to see about what we can do for you. I've almost finished my spiel. But the other thing to bear in mind is the changes we've got coming as well. We're very fortunate to have investment by a very good equity company last year, and the technological developments we're doing with the website. We're on a beginning of a big journey, and you've probably seen some of that marketing. But anyway, that's enough from me. So I'm going to hand over to John and Victoria, who are going to talk to us about the imminent changes to assessment and the future of regulation. John.
Okay, thank you very much. Hope you can hear me, and thank you for that kind introduction. And it's good to see some names on the screen on the chat who I recognise, which is lovely. So I'm John Milne. I'm a dentist in the north of England. I work in Wakefield. Most of my practice is to do with orthodontics, and I work in a couple of practices, mostly within the NHS. So I'm still wet-fingered, but not quite as wet-fingered as I have been as time moves on. So as we've already said, I'm going to deal with some of the theory about CQC, and the stuff that most of you are probably interested in is, well, what does it actually mean for you on the ground in your practices? And Vicky's going to deal with that. And we've also got some questions that we'd like you to think about, and equally well, we'll leave plenty time to answer any questions that you want to pose for us. So, what's the point of CQC? I'm often asked that question, and it's to make sure health and social care services provide people with safe, effective, compassionate, high-quality care and we encourage care services to improve. And like all good organisations, we've been thinking a little bit about ourselves, and we've been thinking, well, what would we like to be? What would we hope to be? And we've come up with this phrase about being a world-class regulator, able to drive improvements in how people experience health and care services and working towards a safer future. That just recognises that not all care is provided safely. And for sure, this time of coronavirus has brought us to a place where the safety of patients has come to the forefront of all our minds. And of course, there have been lots of things changing in our practicing lives on a day-to-day basis just over the last few months. So our purpose hasn't changed, and we still want to encourage improvement with the services that we come up against. So that what we have recognised, though, is that we might actually need to change. And as Alex has already said, CQC changes seem to go in 5-yearly bouts, and we're approaching 2021. And so the time has come for another refresh. And I think from the place where CQC is, the world of health and social care is changing all the time. Changes in technology, changes in the way that care is delivered, changes in the types of people who are delivering care, and that rapid evolution of stuff has led us to the point where we need to think again. And we recognise that actually we don't always get stuff right. We perhaps need to become more relevant and more responsive. And one of the key things that we found is that we don't have a full picture of the quality of care across an area. So, for example, let's think about the town of Wakefield, where I live. We don't know to what extent healthcare is integrated or joined up. We don't always know what the access is to dental care for people in an individual place, and how linked up dentists are with other health professionals. And that's an area that we'll be encouraged an improvement across the sector as we go forward. We know that there are innovative ways of delivering care, and the pandemic's shown us that. People have started doing remote triage. I've had patients take a photo of their swollen face and send it to me, and enable me to work out what the best care is for them. So we're living in a world of change, and CQC needs to take us to a place where we at CQC have got the right tools and right capabilities, and that's what we'll be working on in the future. So this slide is ever so slightly out of date now, because in management speak, people who are much more managerial than I have decided we're working on the now, next, and the future. And we're currently in the next place. Although it says September 2020, it's October 2020. But this for now, where we are, is we're moving forward into what we call a transitional regulatory approach. What we did in the last couple of months was we had these called emergency support frameworks, where we recognised that practices were under pressure, and so we didn't want to cross over your threshold, go through your door at a time when everyone's worried about catching the coronavirus. And equally well, practices are worried again about how they set themselves up to operate safely. So we put in place these emergency support framework calls. Some of you will have had them. I think about 400 practices got these, and they lasted about an hour, and we hope where you had them, they worked well for you. But we're now moving forward into a transitional approach, and in parallel with that, between now and May 2021, we're going to be asking people within the profession, what do you think we might need to change in the way that CQC is operating, particularly within dentistry, although we are asking these same questions across everywhere that CQC regulates, so with GP practices, hospitals, and adult social care as well. The same questions are being asked. In other words, CQC is up for a change, up for an improvement, and we want to involve people in that process. So where we are today is that we're in our 5th year, or we just finished our 5th year. We've looked at 10% of dental practices per year. So we've actually crossed the threshold of about 5,500 of roughly the 10,800 practices that there are in England. Levels of compliance in dentistry are pretty good. dentistry is a pretty safe place. CQC gives sectors ratings. So if you look on your GP's wall, it'll have a great plaque that says CQC say we're outstanding or CQC say we're good. We don't rate dentistry. You either pass or fail the 5 key questions. You get a tick or a cross in the box, which appears on the website. And that's an inconsistent approach. And so we're starting to think about whether ratings might work in dentistry, and I think that will be coming up in the questions later. Practices are now starting to reopen. Well, in fact, most are open now. Working with the guidance that's been given, there's a phased approach in some places, particularly with the NHS, in terms of resuming services. And that's based on the risk assessment, social distancing measures, whether you can get the right PPE, and all the stuff we're all too familiar with around fallow time in the light and the like. So we're starting to look a little bit to the future, and we'll be thinking within CQC about what we've learned from dentistry from our program so far. We've been doing some particular work with care homes and hospitals about how oral health fits in with those environments. And some of you might have been aware of the Smiling Matters report that came out last year. And we know and we hope and understand that the dental profession is going to rise to the challenge of looking after people in the care home network. We'll be learning from what's happened during the COVID pandemic, the changes that are needed in terms of PPE, fallow time and all that stuff, and we're going to be developing our new strategy. So what we're hoping for is that our regulation is going to become a bit smarter. And what that effectively means is, how can we improve our processes? When we cross the door of your practice, will we be there all day, or could we be a bit quicker? Are there some things that we've currently been doing in our inspection process that we need to carry on doing? Are there some things that we can ditch? You know, what are the most useful things to help CQC form a view as to whether practices are a good place for the public to come, and that the care they'll receive is safe and of high quality and meets their needs. So we'll be working together with other partners across general practice and the like. We'll be thinking about, could we use IT perhaps? Our general practitioner colleagues have been doing some pilot work whereby there's a Teams call or a video call similar to this with a general medical practice where people have needed to look at records. That's been made available through the practice's software. How can we think about those things in the future? And I really want to emphasize that we're not going into this consultation period over the next few months with a closed mind. We actually do want to hear what you've got to say based on your experience of CQC inspections and the process so far. And also we're interested in your views on how we might change if we need to. And with that, I'm going to hand over to Vicky, who's going to talk about this transitional approach that we'll be using over the next few months. So to let you know what you can expect and how the process is going to work. So thanks for listening to me. Over to Vicky.
Thanks, John, and thanks, Alex, for the introduction. I'm Victoria Marsden. As Alex says, I'm one of the inspection managers, and I cover the north of England for the oral health team. I've also got a background in dentistry, practice managing dental nurse and dental hygiene and therapy. So that helps with conversations and getting involved in what it means to oral health across all organisations. So I'm going to talk a little bit more about the oral health transitional regulatory approach with lots of acronyms, and I'll try and stay in the full terminology, but it's a bit of a few tongue twisters. So the transitional regulatory approach is the overarching strategic governance, all the detail falls under the TRA transitional approach. Underneath that, we have a transitional monitoring application, and that's where we're being or trying to be a little bit more intelligence-led. We're using technology to support our processes, our inspection methodology more, and that links to the emergency support framework. So some of you, as John said, about 450 practices will have been engaged for an emergency support framework conversation. And the feedback we got was really good around building relationships, actually having a conversation with your friendly neighbourhood inspector, and being able to just have that open conversation about the difficulties that have occurred over the COVID period, what's been put in place, and how everyone's managing to address those difficulties. And from our point of view, we've been able to point people in the right direction where they have needed further help and support. Within this application, it's nothing new. It's part of our existing key line of inquiries, so we haven't gone away and come up with something completely different. We've just streamlined the questions that we're going to ask you. We've looked and asked internal and external stakeholders and asked them what questions matter. What questions matter now, and what type of things should we be looking at? And within those conversations, how can we gather information, evidence where we need to, although this is not an inspection. So we're still not into that inspection territory. This is something else, and it is about building relationships, supporting and monitoring practices. So why you, might you ask? We have inspected 50% of all our dental practices as part of our 10% programme. So that equates to about 5,500 of the 10,800 practices that we have registered, and that fluctuates every day up to about 11,000. But of the leftover 5,300, we may not have crossed the threshold. We may not have had any interaction with any registration, any conversations that we've had. So it's how can we build a better picture of what's going on out there in the dental community, and how can we direct what we do more effectively and reduce the burden on dental practices as well. So a bit of a busy slide, this one, but this is just to give you an overview of the specific key line of inquiries that have been chosen to look at as part of the transitional monitoring application process. And I'm going to go into those in a little bit more detail. So under the safe key question, these are the 4 questions that we've picked out to say these are the areas that we want to look into. So again, although these are similar to what you would be asked on an inspection, it's how you maybe evidence that on a phone call or on a Teams call or on a video platform. And it's what can you bring to that conversation to bring assurance about what's happening now, because we know that maybe children aren't crossing the threshold as much as they used to be. So what processes have we got in place to ensure that safeguarding is still front and centre of what we do? We're also looking at things like antimicrobial prescribing. We know that a lot of this has had to be done remotely, so all of the governance that you may have had in place historically may have changed because it's had to, because of COVID. And then awareness still, what's happening with medical emergency arrangements? Have they been adapted because of COVID? And what COVID management do you have in place for your practice? Within the effective key question, again, these are 3 areas that have been pulled out. So the same type of questions you would be asked. And it would be things like induction processes. If you've had new members of staff, how have you inducted them during this time? Have you had difficulties in getting DBS certificates and checks and things? And what have you done to mitigate those risks? For existing staff, how have you ensured that they've still had appraisals, they've been trained, they've been developed and supported through COVID? And then for patients, how have we managed their expectations? Some of the conversations we've had about what is actually urgent, what classifies urgent treatment, and how can we manage patient expectations? And then for caring, we've only got two aspects in caring, and sometimes it's difficult for us to look at this without physically being in a practice. So how can you evidence that you're caring towards your patients? And it's those conversations. What would you do with vulnerable, nervous patients that come into the practice, especially within this period? If you are doing remote consultations, how are you making sure that confidentiality, privacy, dignity and respect is still upheld? And how do you know that the person you're speaking to is the right person? So all of those things without caring, we may well just have to think about that in a different way. For responsive, and this links a little bit to the effective key question, because it's about that equality, it's about access to services, and we certainly know that access to services has been greatly reduced over the past 6 months. So what are we doing to make sure that we triage and prioritise patients, and how can we follow up on patients' care that have been delayed because of COVID? And again, it's how can we bring that to the conversation you're having with the inspectors? And last but not least, it's the well-led. This is all your paperwork, your governance. We know that there's been so many changes and so many pieces of information of governance and guidance that's out there. And it's what have you taken into consideration? What have you reviewed and what have you realistically put in place to support your staff and your patients during this time? How have you continuously improved, and what systems do you have to ensure that safety? So it links right back up to the safe key question. And I think that's all from me. So back over to John. Thank you very much.
So that's great. That's a whistle-stop run-through of what it's going to be like on the day. I've seen 1 or 2 questions pinging in, which is absolutely fine. And we've got plenty time. You know, we've got half an hour or so now for questions that you want to ask us. These are some questions that I want you to think about. 1 or 2 people have said, well, how can we be involved in a consultation period? Well, we'll be doing 1 or 2 more webinars like this on different platforms. But these are some of the things I'd like you to think about, and you might want to ping an immediate response into the chat or into the question if you want. So I think what you've heard from us is what we're thinking about, and as I say, we haven't decided. We're just thinking about this. Is should we be smarter? Should we be more efficient? Should we spend less time in the practices? Should we only visit practices where we've got concerns, for example? And just to let you know, we're receiving lots of concerns from people at the moment in practices, from dentists, from dental staff, sometimes from members of the public, where people are not sure that they're being treated safely in the current environment. So lots of people are raising concerns with us. How do you feel about the idea of a more regular call from the CQC? So instead of once every 10 years, you might get one of these calls that lasts an hour or so on a much more frequent basis. And I think Vicky's already touched upon the point that what that enables to happen is it means you can build a relationship with your local CQC staff members, with the inspectors. We think that's a good thing. We wonder whether you agree. In terms of rating dental services, we've been asking questions about whether CQC should rate dental services since before I joined the CQC, when I was chair of a general dental practice committee at the BDA. And when the rating questions came up, there was a division of opinion. Some people thought ratings, yeah, bring it on because we're so fantastic, we'll be rated outstanding. And others were perhaps a little bit less sure of the usefulness of a ratings process, because we all know what happens on TripAdvisor, not TrickAdvisor, and on Google, the Google bits and pieces where you can rate. So we know that there are possibilities that if rating is going to be used, it actually needs to work for the profession, and it also needs to work for patients. I think I've said before, you know, if I was looking for a care home for my mum, I really would look at the CQC ratings and the CQC reports. in terms of dentistry at the moment, I'm not sure that CQC reports that might be 5 years old are a key component for people in learning, in working out how to choose a dental practice. So ratings, is it any use? Is it not? Would there be some benefits? And we really are interested in in what you think. We're working on the assumption that the 5 key questions about is it safe, is it effective, is it caring, is it responsive, is it well led, we're expecting those to remain the foundation of what we do. Do you guys think that's appropriate, or might there be any additional ones, or perhaps we should lose sight of some of those things? They're questions I'd like you to think about, and I see in the Q&A there's a couple of no votes for ratings, which is interesting, because, as I say, when it was first talked about, there were certain parts of the profession that were really keen for ratings. Those of you who have children in schools and things like that know that the utility of ratings, let's say it's variable in some parts of the world where rating is used. So it is an open question to us. So I think that's enough from me, and I'm looking to you guys to ask us some questions now. Alex, I think, is holding the pen, and if you just throw in whichever one you want us to answer, we'll do that.
Oh, brilliant. Well, firstly, thank you very much. That was really, really informative, really interesting. Obviously, the strategic side is really interesting, where you're going, where you are, what the future could look like, and the operational side of what this could look like. I think what specific telling the audience which key lines of inquiry you're going to be focusing on for this, I think, is massively helpful. You're not trying to hide anything, you're trying to be open, and you're saying what the assessment's going to be based around. So I think that's really helpful for the profession, and thank you for that. I have a couple of questions myself, which I'll open with just, and then what I'll do is I'll sort of go through the questions list. The first one, and I've got one from the team as well. So I have one from myself and I have one from the code team. The one from myself is just, if we assume, and maybe you don't want to assume, but if we assume that ratings are going to happen. So if ratings are, if we take a crystal ball, we look ahead and we know ratings will happen. I'm not saying they will, but if they did, what would you have to do? What would you have to do to support that from a sort of assessment point of view? And that's to either or both of you.
Okay, well, I'll start off with that one, because somebody has already put in the chat that the issue about ratings is they very, very quickly go out of date, and that is a key component. So what we've done with other sectors that are being rated with CQC, so for instance, general medical practitioners, is they have what's called an annual rating review. In other words, there's a conversation or some sort of contact with the practice, and the results of that conversation will tend to mean that the rating that they've currently got carries on and is upheld. In other words, yeah, you're still outstanding, and nothing has happened to change our view on that. Or it might be, well, actually, your last rating requires improvement, and from what we've seen of you, we'll be increasing that rating. So if ratings were to be introduced, I think it would mean there'd have to be regular contact with practices so that rating remains current. I really must emphasize, though, the fact that we've put ratings into the conversation is not because we've decided to do it, and we're just softening you up for the process. The reason we're asking the question is, what do you think? Is it going to be useful? If it's useful for the public, then that will be a strong indicator for doing it. If it's useful for the profession, that would also be helpful. But if it's a pointless exercise for us to introduce ratings, we need to change some of the regulations around CQC. It will not be something that could happen quickly or easily. So what we're doing is we are testing the water, and to be absolutely honest about that, we are testing the water. I can make a strong case for regulation in the next minute, and I can make an equally strong case for not bothering with ratings at all. So we really do have an open mind. Vicky?
Yeah, and it's just to add to that, you know, we're absolutely open to, if you think we've got it right now, tell us. If you think that the work that we've done with building up our inspection teams, getting the right people in the right place with the right knowledge to inspect, supported by our specialist advisors, we want to hear about that as well, because if that's what's working, then fantastic. We want to be able to take that back. I think John's covered everything about ratings. It's a much wider discussion of what would the actual details of it be, and it's who's it going to benefit. At the minute, is our process benefiting that the ticks and crosses do exactly the same as a rating, and can we turn that around quicker within our process? Instead of having to change a whole rating, we're changing a regulatory process. So lots to think about there.
And just to add to that, just to help you with the thought process, really, because the rating requires improvement, or I can't remember the other one, which basically means it's dire.
Special measures.
Special measures, unsatisfactory, all of that sort of thing. But because of the ratings are a little bit more nuanced, one question you might think about is whether the ratings themselves will help practices work out what they might need to do to improve. It's a little less harsh than saying this practice does not meet the safe key requirement, when it may be that some of the things that form that judgment are actually things that are reasonably simple and reasonably easy to sort out. So there is a question: to what degree might ratings be helpful in actually guiding practice as to how they might improve? So you need to think about that as well. Somebody's just said you'd need yearly inspections. I think I've just sort of covered that in terms of the what might be a phone call or something like that. But as I say, we keep telling us what you think, because we really haven't made our minds up one way or the other.
We're listening.
Brilliant. Well, thank you so much from that one. The other one was just one we've had from this, actually one that came before. This is from our helpline team, where they've asked me to ask you specifically that they're aware that some practices are currently having focused, and I am reading off the other screen, currently having their focused inspections and registration inspections via Teams. So that's been happening currently. Is this going to be the new normal going forward, or is this a COVID interim? And what should they expect from these online inspections in terms of evidence submission?
Well, we haven't made our minds up on that point, but I think one of the things that we've all learned through this pandemic process is the utility of things like Teams, and so it's not hard to imagine that it might be extended from beyond the registration point of view to our actual conversation with a practice. So I think our minds are open, and like everyone, we've seen how much technology can work. Vicky, you want to add to that?
Yeah, it's reducing the risk as well. It's what do we actually need to physically see if we cross the threshold, and if it's not a necessity for us to physically see and go in, can we reduce that burden again, and the time and effort and energy that goes into everything at the moment by doing this remotely? Can we have that call? Can we ask for supporting evidence, whether that be digitally, sending policies, all of those things, having conversations with staff members about what is going on there within their practices. So it's about us being a little bit more proportionate. It's not just an instant trigger over the threshold as it may well have been before. It's how can we best review the information of concern potentially that we've received, or how can we review information within our systems to get the best outcome for everybody.
Alex, can I just answer a question that's popped up in the chat bar?
That's where we were going next. So please.
So Mark Woodcher, hi Mark, has asked a question about whether patients would conflate the rating of a practice, if we were rating, with the quality of dental treatment from their dentist. And that is an interesting question. And one of the things that we often struggle with at CQC is that we are actually meant to look at what is effective dental care and what does that mean. And I sometimes describe this as meaning, well, what are the chances that the treatment my mum would get, that treatment will improve or maintain her oral health? And those are real questions about the quality of dental care that's given, including the quality of the technical work that we sometimes do. And I think as we're looking forward over this next few months to conversations, we will be interested again to hear about how we might be able to do that. The Dental Reference Service, as you all know, was disbanded in England. The Business Services Authority feel that they can actually make a pretty good assessment of the quality of dental care by looking at notes and looking at records. And as you know, that's something that we often do in the inspections in the old style. How might we be able to do that moving forward? With Teams, might you hook us up to your IT system? There are all sorts of possibilities, and our minds are open to those. But Mark is right. If there was a rating, the rating goes to each of the 5 questions. So you could actually expect the effective rating to have some measure in it of actually how good the care is that people receive.
We do include that a little bit already now, because we ask for patient comments as well. So it's not totally new. Yeah,
and I understand that in the some of the thinking around NHS reform that may or may not be happening, questions there have been asked about, well, what are outcomes like for patients, and should we be looking at outcomes? And it seems to me to be a perfectly reasonable question about the quality of care. Does it improve your health?
Thanks, John. I'm moving over to the Q&A panel now. The most popular question at the moment is from Hannah Fry, and it's a classic. It would be really helpful if dental practices are emailed with guidance that we must follow, instead of having to, from the CQC, I think is the suggestion there, instead of having to go looking for it and then interpret the message. Is this something that the CQC have it currently in the pipeline?
Who's picking that one? Go on. All right, I'll start. I think the stock standard answer to come from CQC is that you're a dental professional, and actually you can look at all the guidance that's out there as well as we can. And what we expect you to do as a profession is to work out for yourself what the best way of practicing professionally is. Now, given that we are about encouraging or driving improvement, I think I would hope that will be something that we'll give some thought to developing again in this next 5 months. I know sometimes, and I'm sure that Vicky will have found this, that as an experienced dental professional, you sometimes want to say, might you think about doing it this way rather than that way? But the problem is there are always 100 different this ways and that ways, and that makes it tough for CQC as well as for you. So I don't think we're likely to give a list, but we will make it. The information about what we'll be looking at will be available on our website, I would expect, in terms of the way the key lines of inquiry currently are available.
And we've also got the Mythbusters as well. So where we do find that there's key themes, we develop Mythbusters to try and reduce that ambiguity out there as best as we can.
Yeah.
I think we always say at Code, for me, and you can correct me if I'm wrong, the CQC are there to regulate the profession. It's akin to asking the police to send you out guides on the law. In a way, the police wouldn't send you a guide out on the law. You're supposed to know it as a member of society, and you're supposed to be aware of these things. But the Mythbusters are massively helpful, but also from how you create a particular log or do something in a particular way. There are many ways to meet the regulation. It's kind of what works for your practice, and you wouldn't want to give someone this is the one way it should be done. That's kind of how I see that as well. Okay, Firaz has said, will there be a handout available for this presentation? We're pending information on that. This webinar will be recorded. It will be available on YouTube very, very quickly, most likely within the next 24 hours. Everyone, I believe people who were signed up will get an email to tell them that it's now available as well. So that information will be there for people. If we are able to give a handout as well, we will email everyone as well. I can almost guarantee if you ring up the code helpline and you ask for one, currently you're going to be told we don't have it. So I'd rather people didn't choke up our helpline asking for a handout that we can't give out right now. And I think unless John, Victoria, you want to come in on that, I think I've probably answered that to your satisfaction as well.
I think you have. Some of the slides that we're using are internal ones that are still in development as we're thinking about our strategy. So it's what we've shown you today might change tomorrow, but we hope we've given you a flavour that we're thinking about change and we're listening to your views.
Thank you. Joe Russell has asked, I think that the CQC should follow something like an accreditation scheme and ask for pieces of information annually so that there's a consistent flow of information regularly, so it isn't all done at once before an inspection. What would be your view on that, Victoria, if we go to Victoria first?
It would be wonderful, I think, if we could work in that way to try and be able to assess information remotely, because half of what we do on the inspection is look at paperwork and have conversations. So if we had the capacity to look at all of that information, and then if there was any questions that needed to come out of that, it would be more targeted approach. Great. It's more the 10,800 practices sending us all of that information on an annual basis. We would have to think very smartly of how we took that forward.
Okay. John.
And accreditation schemes are interesting, and we've considered this quite a bit over the years. I think our general view is that the individual engagement with an individual practice is what best gives us a position about what the quality of care is in that particular place. Yes, it's the quality depends on the individuals and the professionalism of the people in an individual practice, and so accreditation's great, and we love to see it. But equally well, we like to have that relationship with a particular practice.
Fantastic, thank you. Mandar has asked, why are all policies expected to be in hard copy form when all other aspects we're moving to a paperless world? I believe that they don't have to be in hard copy form, and as a digital platform provider, it's sufficient for people as long as it's access that's important and the team having access. Would we all agree?
Absolutely. Yeah, I don't care where you've got your policy, long as it's accessible, everyone knows where it is, and long as if we're on inspection as well, then you can point us in the right direction to happily scroll through your policies. If it's digital or paper, we don't mind either way.
I'll never forget going to do an inspection on a practice for code, obviously, and I was told all the policies, we don't print them out here, all the policies are on the P drive, and said, who has access to the P drive? Oh, me and the manager. So it didn't, so that there were a load of policies there, but the team had never seen them. So I think that's the situation to avoid. Emily said it would be good to have a good relationship with an inspector instead of people having to worry about the inspections or seeing them as something onerous. So I think that's someone saying it'd be great to have that regular touch point and getting to know them. That's got 8 upvotes. It's one of the most upvoted, so that's obviously a popular. Everyone wants regular calls from their inspector, I think is how we're reading that
Fantastic.
One, right? So Jonathan Jacobs, hi Jonathan, I hope you're well. He said under this new regime, I think he means what you're thinking of post May 2021 rather than the TRA or TMA. when an inspection takes place, will it still be the case that a clinician and inspector will attend for a day and the patients will be surveyed, etc.? John?
That's our working assumption. So we think it's really important that the team that's involved with inspections of dental practices, whether it's remote using IT, or whether it's going through your door and meeting you face to face, we think it's really important that the inspection team knows what they're talking about. And we've spent a lot of time in the last 5-6 years building up expertise within the dental team. Our inspectors mostly do dental practices, and the dental professionals that go with us, specialist advisors, are dentists, and we have some hygienists, therapists, practice managers and nurses. We've got a mix of people, but everyone who's involved knows about dentistry. We still think that's important, and we hope that that'll continue.
Fantastic. Right, where were we? I think one of the things on that, just to sort of see if I've understood the context, is that the inspections will happen, but it's what you're scoping or what you're trying to consult on as well is the inspections don't necessarily need to be the routine. There might be a more routine contact that if that goes in a way that the practice wouldn't like, that would lead to an inspection. But the routine inspection isn't going to be the thing. It's going to be almost a follow-up. Would I be reading that correctly, Victoria?
I think it's really looking at a mixture of everything. I don't think it's going to be one defined thing as it was before. I think we've got to be really aware that one size doesn't fit all, and that's what we're trying to be. We're trying to adapt our processes to understand the impact of us going into a practice for a whole day. How can we work around that? Can it be that we can do some remote? Can it be that we spend less time on site? But I do think there will be times where we still need to spend a whole day with a practice. So I wouldn't want to count anything out, but I'm very much willing to count everything in.
Okay, no, that's brilliant. Joe Russell has asked, how can we be involved in the consultation process of improving I think that's probably a great question. How can the members of the profession get involved in the consultation?
Right. Well, first of all, you're involved by being on this call, and I'm looking very carefully at what's coming up in the Q&A, and I'm hoping that Alex will be able to share with us the questions that you've asked. We've got set up over the next couple of months. We've got calls with all of the representative organisations around dentistry. So we've got calls with the British Dental Association, with the FGDP, with the Royal College of Surgeons, with the two associations that represent dental nurses, and also with therapists and hygienists, and other regulators like the GDC. So we're spreading our net really widely. The other thing that's going to happen is that there are going to be a couple of webinars that we hope will get wide audiences like you've got today, with members of our dental team, and probably the Chief Inspector, Dr. Rosie Benimouth, who's a GP. So we're going to be putting those out to try and reach the people who are not themselves involved with local dental committees. We'll be speaking to them as well, and also to the regional groups of local dental committees. So we are going to be speaking to everybody that we can. I think that's about. I don't think I can say any more than that, because I don't think we'll be holding many face-to-face meetings in this sort of COVID time. I know in the previous iteration, when we changed the methodology back in 2015, there were lots of meetings that dentists were invited to, but the numbers of dentists at that time were small. So I think this platform of IT enables more people to get a voice and have a say.
Yeah.
I am just conscious of time and the volume of questions we have, so I'm just.
By the way, if questions want to stray outside of this, I don't mind. It's okay. We're okay. We're okay for a little overrun, but it must only be a little one. You know.
What 10 minutes, so 10 past 2, something like that. Is that works for you? Well, thank you. That's very gracious of the two of you. We appreciate that. Let's have a look and see what we've got on here, which I think would be we've got how to be involved in the ratings.
I think there was a question before, Alex, just about whether if you've had an inspection and an ESF process, whether that will mean that we don't cross the threshold again.
Brilliant.
With all of what we do, everything we've got to take into consideration risk. So if we get new information of concern, it may well be that you were inspected last year. It may well be that we've done an ESF and a TMA and we take all of that into consideration. But if we feel that the information that we receive is credible and justifiable enough for us to cross the threshold, then there is still that option. So just by having an inspection, an ESF or a TMA doesn't sort of tick you off forever. It all depends on active information that's coming through too. And hopefully you would all agree that we've got a duty of care to look into those concerns as well.
We've got two here that are quite similar. The first one is if a practice has recently been taken over, will you be doing a face-to-face inspection or remotely? Will an inspection happen within a certain time frame of the takeover of that practice? And the second one is if a new practice opens, so a brand new build, would that be on site? Would that be done remotely? How's that working?
I think, and Vicky will correct me if I get that wrong, I think if we can, we're doing it remotely using Teams and things like that. So in other words, it's waft your phone around and show me the new surgeries and all of those types of things. I think where we can, we're trying to avoid the face-to-face visit if we possibly can.
Yeah, certainly for the registration question, the brand new practice there, Alex, that would absolutely be the point. For somebody taking over a practice, it would be very dependent on lots of factors. Have you had a practice before? Have you been registered managers before? Are you the first time we've ever heard of you? But again, within that registration, taking over a practice, the team would try and do that remotely wherever possible.
Yeah.
Fantastic.
Really quick one. Somebody said 50% non-inspected. Is that ever or in the last X years? The answer is it's in the last 5 years. Before that, 100% of dental practices that were registered were looked at between 2012 and 2015.
I guess then with the one interesting question I've got about is with the TMA. So what are you still with the sort of interim before you put in a new strategy? What's the sort of volume you're thinking of for the TMA? Is it still 10% who will be getting a call instead of an inspection? Because my understanding is this is, unlike the ESF, this is a mandatory call that people will have to engage with.
I think Vicky knows the number.
Okay, brilliant.
So we're looking at about 1,500 of the TMA calls, and again, that may well come up a little bit if we've got risk associated that we've got to factor in. But I think we've got some wonderful mathematicians within our organisation that have said that they're the number that would take priority for us to do the TMA calls with up until May, 31st of May 2021, I believe. 1,500
calls between now and May next year. So higher than inspection volume.
Yeah.
Used to be. Okay, no, that's really interesting. So people, that's really interesting. Someone's made a comment about the audit. We've had a couple of comments about the audit mythbuster. I'm not sure what that's referring to off the top of my head. Would you be able to shed any light on that, or? We
can certainly pick that up and have a look at it outside of this space. Me and John can look at that afterwards.
Yeah,
fantastic. So what's the CQC's view on places offering injectable facial aesthetics outside dental and medical clinics?
Really interesting question. And most facial aesthetic stuff is outside the scope of the CQC's regulation. The GDC have their thoughts about whether you should use your dental registration as a selling point to entice people to take up those services. But at the moment, it's not in the scope of regulation with CQC.
I think you're already covering this, but someone said, as we have the model hospital, would we ever have the model dental practice to give a guide to what a best practice would look like, or best practice case studies? I believe you're already doing this on the website, aren't you?
There's been a little bit of that with where we've looked at notable practice. It's a fairly dangerous place to be, but I'm sure there'll be some people out there who would like to volunteer theirs as a showcase.
Yeah, I think for notable, it's normally one aspect. It's not that your whole practice has to be at the amazing notable standard. It's an aspect that you're doing that impacts on patient care that we try and sort of pick out and highlight as best we can.
Okay, John has said, surely CQC's role is to ensure practices work safely, so either safe or not, pass or fail.
Simple.
Well, that's the way the current methodology sort of works. But you've got to actually think that there are some things within the safe key questions that we ask. There's such a lot of questions there. As George Orwell said, all animals are equal, but some are more equal than others. And I think in terms of safety, that's the position that we're in. If you haven't got an autoclave that's working and you can't sterilise your instruments properly, then there's a real risk that people are going to come to harm. And so there is a nuance in all of those things, and we mustn't forget that.
Fantastic, thank you. Ravindra has said a rating system might be counterproductive, as say a missing incomplete protocol might mean a 4-star rating when the clinical care could be excellent.
Yeah, fair point.
I'm just trying to scroll. There's a lot of statements in here, so I'm trying to scroll past statements to find questions. So that's why it's taking me a little bit longer, but it's really good. We will, if we can share this with you, we absolutely will. I'm not sure if we can export this from the platform, but it's a very good platform. So I imagine it would be possible.
If you could, it would be really helpful because it gives us an opportunity to see what people are saying. You can take the names off if you like, because if somebody puts someone in there, we don't want to. You don't want you to feel shy about saying what you're saying, though. If you say something that's critical or difficult, it doesn't mean that we're going to be coming around tomorrow morning.
Unless you want us to. There's one question that's come up about registration, that if you've added more surgeries into your practice, do you need a new inspection? Not at all. You just need to update your statement of purpose and let us know.
Lorraine has said, John, the approach to telling professionals to work it out themselves creates unnecessary pressure. CQC should just state what the minimum standards are and allow people to build from them. An improvement partner approach rather than what feels like an exam to see what you got right or wrong? Question mark. That felt like a statement at the end there, but I think you've already covered this. But would you like to cover it again?
No, I think I certainly think it's an interesting point of view. The General Dental Council, of course, takes the same position. It says we're here to assess whether what you're doing is safe, effective, and all of those things. And the GDC look to see that you're a responsible professional behaving in the right way. I think it's unlikely that we're going to move to that from that position, but we are nudging a little bit way towards helping people with our things like Mythbusters and the like. So I think it's unlikely that one's going to move. I know it's really, people say to us, why don't you just tell us what to do and we'll do it. And sometimes I wish we did that, but actually, there's much more to it than spoon feeding people. It's about professionalism. Is a state of mind as well as a state of what you actually do in your day-to-day practice. And I think we would encourage professionalism, absolutely.
Mm. And just as part of business as usual inspection, we did used to send quite a lot of information 2 weeks prior to the inspection to try and at least give a flavour of the type of things that we would need to look at so that the practice could prepare more for the inspection. And the key line of inquiries are what we inspect against, and they're on our website as well.
Yeah, now we've got a really interesting question from Joe Russell. Joe Russell is asking a lot of questions. Is it acceptable for practices to still be using the 3 A's, advice, analgesics and antimicrobials where necessary, and doing no face-to-face at all? At the risk of being controversial, I'm struggling to see how, given all the information that's come out about how to practice face-to-face in a safe manner, I'm struggling to see why that might be the case. But there may well be a dentist out there who themselves is shielding or something like that. And so there may be the odd particular circumstance that means that a practice might have to operate in that way. But I think I'd be disappointed if it wasn't the exception rather than the rule.
I have one question here that I find quite interesting, and I promise that we did not plant this one. That it just says, no, it's an interesting one. It's not a what you think of the system or anything like that. I think if you were able to access our compliance system and check yourselves with no content, if you were able to access our compliance system, then you would be able to check with no content unless you had concerns raised. So obviously technology does allow those sorts of things. I equally would be interested in your opinion on that one.
Got to be fair for everybody.
No, any compliance system. I'm not talking about ours.
No, but not everybody has a compliance system, so it's that fair and proportionality of being able to access for everybody.
And I think one of the challenges always is, isn't it, whether it's a compliance system that's commercial or whether practices have done their own. You can have all the policies in the world, but unless the staff understand what they're doing and why, those policies are a bit of a waste of time. So just a remote look to see that a practice has a policy probably isn't enough on its own.
It's always a challenge for us as well, is how do you, especially when you're building reporting into the system, how do you make that reporting accurate and real, rather than something that is fudgeable by someone. So I think it's an interesting question. And I think we've pretty much, I think we can get one more question in before the end. And let's see, can you see any particular question that you would love to answer, John and Victoria, before I try and find one? Because I'm in a lot of statements at the moment.
Somebody just said, how will we be contacted in the first instance for a TMA call? Vicky, do you want to take that?
Yeah, we will either pick up the phone in the same way we would have done to announce an inspection before, and we'll work with you to find a suitable time. If we can't get through on the phone, we'll ping you an email and ask you to respond in a suitable time to book something in. So we give you 2 options.
Brilliant. Well, I'm just going to wrap it up now, because thank you for giving us the extra time, and just to say thank you to both of you for your time and for doing this, and for your extra time on it as well. It's been really informative, really helpful, and I'm sure as this develops, we'll invite and see if we can make this work again at some point when we're further down the line with it, when there's new information. So I'd like to say thank you to both of you, and thank you to all the members and everyone for attending. Obviously we do have a system that does help with compliance, and if people we will help people weather the changes. So there'll probably be a pop-up, if you excuse me, appearing on your screen right now. Just if you're not endorsed by the CQC, I will say that. And yeah, just thank you, John. Thank you, Victoria, and thank you everyone for attending.
It's been a pleasure, and it's been nice to be on a webinar where we haven't been discussing fallow time.
Yeah, let's get right. Everyone leave now. Everyone get out. Yeah. So well, I think it's good timing. The fallow time thing pretty much got resolved, didn't it, at the end of last week? So it was good timing for this webinar. So I hope everyone has fantastic days, and yeah, we'll see you on the next webinar. Take care, everyone.
Okay. Thanks, everyone. Bye.